of the hour, we're going to go ahead and get started. Thank you all for joining us again for this symposium. I'm going to turn it over to my colleague Yolette Gray, who is the Senior Manager of Public Policy and Community Engagement, who's going to introduce this session.
Thank you, Julie. Good afternoon, everyone. This next session will review the opioid crisis through the lens of maternal health, with a particular emphasis on hospital-based opportunities for intervention. Specific attention will be placed on screening, reducing stigma, and the inequities grounded in that stigma. Our presenter for this session is Dr. Mishka Terplan. Dr. Terplan is board certified in both obstetric and gynecology and in addiction medicine. His primary clinical research and advocacy interests lie along the intersections of reproductive and behavioral health. He is Associate Medical Director at Friends Research Institute, Deputy Chief Clinical Officer, Addiction at the Department of Behavioral Health for the District of Columbia, an adjunct faculty in the Department of Family and Community Medicine, University of California, San Francisco, where he is a substance use warm-line clinician for the National Clinician Consultant Center. He is also a consultant for the National Center on Substance Abuse and Child Welfare and the Addiction Medicine Specialist for Virginia Medicaid. Dr. Terplan has active grant funding and has published over 100 peer-reviewed articles with emphasis on health disparities, stigma, and access to treatment. He has spoken at local high schools and before the United States Congress, and has participated in expert panels at CDC, SEMSA, ONDCP, OWH, FDA, and NIH, primarily on issues related to gender and addiction. Thank you, and I will now turn it over to Dr. Terplan for his presentation.
Great. Well, thank you, everybody. It's a pleasure to be here, and thank you for that really kind introduction. So we're going to be talking about the opioid crisis through a specific lens of pregnancy with an emphasis on the postpartum period. So I want to ground this conversation in history and in a bit of epidemiology, and begin by noting that using substances is actually part of human culture. Almost every single culture described by anthropologists use substances, but the idea of addiction or drug problems or the population health consequences of substance use that we call addiction today, these are a modern phenomenon. And they date really from the 1700s. And the first drug epidemic was alcohol, following the distillation of higher potency gin in particular, but other spirits, coupled with sort of rapid urbanization and collapse of agrarian economies. Northern Europe had, and the United States had, an epidemic of addiction. And also, women figure in the early drug epidemics in ways that we don't think about necessarily today, as illustrated by this lithograph, a depiction of addiction, and front and center is a woman who is neglecting an infant that is falling over the railing. Now, the second drug epidemic globally really were opioids, in particular morphine, around the turn of the 20th century. And at least 75% of people who were addicted to opioids at that period of time were women, predominantly upper class or upper middle class white women who had been exposed to opioids initially by their physician for the treatment of female ailments. As illustrated in this textbook from 1902, the disease was called morphinism. And you can see here, within a few years, many authorities have pointed out the danger of morphinism in women who come under treatment for gynecologic disorders. So the hypodermic needle was invented around the 1850s or so. And the first person to die of a drug-related injection overdose was the wife of the person who invented the syringe. And the oldest image of anyone injecting a drug is this lithograph of a woman injecting morphine. an image so common that it was reproduced on postcards. This was a postcard that somebody purchased on the streets of Paris in about 1905. So you might wonder, how was addiction understood during this period of time? And it was understood as a disease, sort of using the framework that Dr. Benjamin Rush had delineated for alcohol addiction, which he called alcoholism, that was applied to the addiction to morphine, known as morphinism. And medications were prescribed, in particular, short-acting opioids, which were the only opioids that exist, not just for detoxification, but also for treatment, for maintenance, quote unquote. And these clinics, some of which existed and were embedded in police departments. Now, this all shifts in the 20th century when, Harrison Narcotics Tax Act, addiction becomes understood as a criminal, not a medical condition, and the image of a person who uses drugs changes as well, from a white, upper middle class woman to a non-white man. But I tell this story because there are parallels between that crisis and the current crisis. The two parallels are, one, both are to a certain degree iatrogenic, i.e. caused by physician behavior, in particular opioid prescribing. And two, this crisis has a large proportion of women, just like the first one. So, this is a question I often get. Why would someone who's pregnant use drugs? And I don't think this is the right question to ask. Most people across their lifetime have used a substance to which some people become addicted. So the proper question really isn't, why would a pregnant person use drugs? But what happens when people who use drugs get pregnant and stay pregnant? So these are data from the National Survey of Drug Use and Health, cross-sectional, looking at past 30-day drug use stratified by not pregnant reproductive age, pregnancy by trimester, and then separated by substance. And you can see a couple of things. One, people who are not pregnant are more likely to have past 30-day substance use. Use declines across the course of pregnancy, and it differs by substance. People cut back alcohol the most, cigarettes the least, and illicit substances, which in these data are about 80% cannabis, somewhere in between. So I look at these data, and to me, they support the statement that everyone who's pregnant is motivated to maximize their health and that of their baby-to-be. Nobody thinks smoking cigarettes in pregnancy is a healthy behavior. Some people can stop. Other people can't stop. Those who can't stop using a substance during pregnancy, they likely have a substance use disorder. You can think of sort of pregnancy as a natural experiment that separates use from use disorder. People who continue to use through the course of pregnancy likely meet criteria for addiction. So this is important because when we're talking about substance use in pregnancy, what we are not talking about is people who within the gestational window develop the disease of addiction. I have never ever seen that or heard of that. I've certainly diagnosed people for the first time in their lives with addiction in pregnancy, but it does not arise de novo during gestation. What we are talking about then is where, the reproductive health life course, getting pregnant, staying pregnant, delivering a baby, intersects with an addiction life course, use progressing to misuse, progressing to addiction in the specific period of time of pregnancy. So today I want to talk about 4 related topics. 1, assessment for substance use. 2 is analgesia during labor and delivery hospitalization. 3 is the 4th trimester or the postpartum period. And 4 is stigma and discrimination. So screening and testing. I think we need to sort of think about these terms. And let me define them. By screening, I mean having a conversation with a patient or using a validated instrument. Testing is looking at biological sample, primarily or most commonly urine, and looking for metabolites of certain substances. And we can apply both of these, either screening or testing, in a universal manner, which means we provide everybody who is seen, it gets screened or tested, or it can be selective, i.e., only certain people will be screened or tested. So the recommendations by ACOG is for universal screening using a validated instrument. And the reason for universalism is because selective screening based upon, quote unquote, risk factors perpetuates discrimination and also misses people who don't fit your preconceived ideas of who a person who uses drugs is from, being identified and getting referred to treatment. It's also recommended that this screening happen at the first prenatal care visit. And this is because the earlier we can identify substance use or addiction in pregnancy, the more time we have, to work with somebody through the gestational period. And that graph I showed you before really highlights the motivation that people have for care during this important life period. I agree with ACOG, but I would add a wrinkle to it. And that is, before screening, ask permission. Is it okay if I ask you some questions about smoking, alcohol, and other drugs? And the reason for that is to ask people's permission and respect what they say, because all of the work we do in behavioral health rests upon a strong therapeutic alliance. And asking permission and respecting what they say goes a long way in establishing it. And if the patient says, no, it's not okay, then I don't ask. Because the one thing that's true about prenatal care is that there are multiple visits over time, and that there's very good reasons that people might not feel comfortable disclosing use initially, and you want to build that alliance by treating people with dignity and with respect. So there are several different screening instruments that have been validated in pregnancy. These are on the slide, and these came or were summarized in this table from this clinical guidance document from SAMHSA, which I would encourage anyone who's interested in this topical area to download. It's free and it's an excellent, excellent resource. So we have instruments that are validated in pregnancy. And the reason for screening is to identify people who are at risk, perhaps, of having an addiction, diagnosing them and referring them to treatment. And this is the core principle of maternal child health and all of prenatal care, which is the treatment of chronic conditions improves birth outcomes. That is true for diabetes, it's true for seizures, it's true for hypertension, it's true for addiction. And these are data from Massachusetts, the most recent data that look at this, and I stratified it by the group of people without a substance use disorder, those with treated addiction and untreated addiction. And you can see that people with treated disease look much more like a population of people without addiction than those with untreated addiction. And when we talk about risks of substance use, we rarely stratify on treated versus untreated. And really what we're talking about is the untreated state rather than the treated state. So as mentioned, there's lots of barriers to screening. On the patient side, there can be fear, legitimate fear of discrimination or judgment, oftentimes based in prior negative experiences with healthcare providers. There's fear of child welfare involvement and notification. And some people don't, consider their use to be problematic. Like I mentioned, pregnancy is an opportunity, for diagnosis and treatment. And providers have barriers too. There's an absence of competence, of attitude, and for some people, they can, feel like people who are pregnant and use drugs are not deserving of care. So I'm contrasting this with urine drug testing, screening, and there's two types. One is the point of care, which is the urine cup. It's a rapid test result. We use it often in addiction treatment, versus definitive testing, which is, using a mass spec or other sorts of technologies and takes a while to get. The point of care drug test is binary. It's a, positive or negative. And oftentimes we think of it in this sort of pass-fail, which is grounded, in this history of using the test as a tool of control and punishment, which is improper and unethical. The problem with these point-of-care tests is not just because it's a binary result. The detection window varies by substance. Some things linger for a long time in the biological compartment. Others are metabolized rapidly out of the system. Only certain things are tested for. Alcohol is a really bad, urine drug testing is not a good way to assess alcohol. And there's many medications that can cause false negatives or false positives. And it's these limitations that have, grounded ASAM to state that if you're going to change your clinical, course based upon a drug test, it should be based upon a definitive test and not a point of care test. And I would argue that any test in pregnancy, due to the child welfare ramifications, needs definitive testing before you make the notification. So there's lots of limits of drug tests. We use them as a parenting test, which is completely inappropriate. We need a much more sophisticated way to assess, child safety than just a point of care drug test. We also sometimes use them as a test for addiction. Addiction is a chronic brain condition, affects the whole body, but the symptoms are behaviors, craving, compulsive use, continued use despite adverse consequences. A toxicology test only assesses metabolites. It says nothing about behavior. And patient consent is required before urine drug test specimen collection based upon a Supreme Court ruling that I am happy to talk about in the question and answer period. So it turns out that physicians are really bad at interpreting drug tests. This is one or two studies that used this 7-question survey that I think is simple enough for almost every medical student. You get 100% on it. In this survey of general practitioners, nobody got 100%. And in fact, people who used urine drug testing in clinical practice scored even more poorly than people who did not. There is a whole history of racial inequities and child welfare reporting based on urine drug testing. And this is the classic article from 1990, in which they looked at positive urine drug tests comparing Black and white women in Pinellas County, Florida. And basically the results are the same. About 15% of both groups had a positive drug test. However, hardly any white women were reported to child welfare for the drug test, and most of the Black women were. In fact, Black women had 10 times the likelihood of being reported compared to white women. And this has been an argument, or these data have been an argument for universal screening, right? If we test everybody, or if we screen everybody, we're going to reduce or get rid of the racial inequity in reporting. And that actually does not happen. These are more recent data from a county in California looking at before and after universal screening during pregnancy, and they found a persistence of a racial inequity in child welfare reporting following universal screening adaptation. And Black and Latinx parents had 4 times the odds of being reported compared to white parents, despite the fact that screening results were actually more positive in the white population. So in conclusion around screening, I'm drawing this from a commentary, and I'm just going to read it. Although universal voluntary screening would seem the most reasonable approach, physicians should advocate for that only as strongly as they advocate for social support and addiction care services for those subsequently identified. Second part, we're going to talk about analgesia on labor and delivery, in particular for people who are receiving medication for opioid use disorder. And the principle is clear. Pain should be treated. And the medication that people are receiving for opioid use disorder, be it methadone or buprenorphine, are not analgesia. That is their baseline. And in fact, people with opioid use disorder oftentimes likely need more pain medications than people who don't have opioid use disorder. The principles are multimodal, using non-opioid pharmacology plus opioid pharmacology plus regional anesthesia, which we can do so well during pregnancy. So when people present to labor and delivery, we want to continue the medication through their delivery hospitalization. We need dose verification to know what the dose is to give them. During prenatal care, our conversations need to be people-centered, and we need to discuss what to expect when they're expecting in terms of both NAS, which I'm not talking about in this talk at all, and especially analgesia. And people need to be assured that your pain will be controlled during delivery. What about discharge? Really, opioids are probably not indicated for uncomplicated vaginal delivery. They might be for cesarean delivery. NSAIDs, should be standard. You can prescribe opioids for a short course to somebody receiving medication for opioid use disorder. And hospitals really need to have, prescribing guidelines specific to labor and delivery that make adoption and, standardization of this easier to implement. So the third thing I wanted to talk about was the postpartum period. And I'm re-showing this cartoon because I want to highlight the fact that pregnancy is an opportunity, to provide services, but there's a lot of the life course that precedes it and especially follows it. And generally speaking, we do not program very well in this space. I like the term fourth trimester because it's inclusive of the rest of pregnancy, and the postpartum period is defined as 1 year following delivery. And this is a really critical moment. This is, when the mythic image of the ideal mother collides with the reality of caring for the newborn. This is where we actually withdraw care. People go from weekly prenatal visits up until delivery to oftentimes one postpartum visit afterwards. This is a time of mood changes, sleep disturbances, physiologic adjustments. This is where care shifts from being, medically focused to non-medically focused, from being maternal focused to newborn focused. And this is such an important period, the insurance churn, that I feel like we oftentimes neglect. So one of the greatest success stories in public health in the 20th century is the reduction in maternal mortality, the likelihood of dying during childbirth, which had been, 5% or so, during that first opioid crisis, plummeting to when, I was in training and about 1 in 10,000 women died. As I hope everybody knows, that rate of maternal mortality has only been increasing since I was in training in the United States, in contradistinction to the rest of, the so-called whatever developed world, as you can see on here. And a lot of this, there's been attention to this, especially around racial inequities, which are really grounded in racism, which in our country is grounded in, the false ideology of white supremacy. And this is such an important topic to talk about. Black women are 4 times the odds of dying compared to white women in the United States. But I can't do that topic justice. I'm concentrating here on, opioids and maternal mortality. Because people with opioid addiction have 4 times the odds of dying during the delivery hospitalization compared to people without opioid addiction. And these deaths actually are more common following the hospitalization. These are data from Colorado, but almost every state that has looked at this has found overdose to be one of the leading causes of maternal deaths in the United States today. And you can see in Colorado it was the leading cause. It's not just opioids, although they're the more common substance. There's other substances involved in the maternal deaths. And you can see here when the deaths occurred, most of them happened through the postpartum period when we're not providing care, rather than during the pregnancy box when we do provide care. One thing that happens after delivery is medication discontinuation. This is a graph just looking at the percentage of people who continued with the medication following delivery, and you can see a marked attrition through the first year and thereafter. And there's a strong association between remaining on medication and not having an overdose or dying of an overdose. These are data from Massachusetts. The top is looking not just at fatal overdoses, but all overdoses. And you can see that the rates of overdose decrease through the course of pregnancy, only to increase postpartum. And in fact, later postpartum rates of overdose are higher than they were the year prior to delivery. And on the bottom, you can see the protective effect of medication for the outcome of overdose. Now, there's a lot going on in why the postpartum period is so vulnerable for overdose and overdose death. But one thing has to do with gendered assumptions about who a person who uses drugs is. And these are data from Rhode Island, from EMS, looking at who got naloxone, by emergency medical response. And whereas, 75% of men with an overdose got naloxone, less than 50% of women did. In fact, women had 3.5 times the odds of not receiving naloxone than men did. So we need to, I think, focus on this postpartum period. The time of increased vulnerabilities is actually when we withdraw care. Overdose is one of the leading causes of maternal mortality, and continuation of medication is essential. So is co-prescribing of naloxone. So in the hospital, everyone with an opioid use disorder, everyone I would say with a substance use disorder, anyone who is prescribed opioids should be leaving the hospital with a naloxone prescription, or ideally with the naloxone itself. So the last thing I wanted to talk about was stigma and discrimination. And I want to frame it around a story. This is Lindsay Jarrett. I took care of her for her second pregnancy, and this was a piece that came out in the New York Times a couple of years ago, looking at her first pregnancy when she had untreated opioid use disorder, delivered, her son was placed into foster care, and it details, her attempts to get her son back in her life. And I want to focus on the comments. This is from the online New York Times. Using H while pregnant is the deal breaker. Sorry, lady. Sure, the parents love the child, but do they love him more than heroin? I have no sympathy for her. You use drugs while pregnant. You do not care about the child. There are consequences of being a junkie. You just don't return to life expecting all you had before. And really the most succinct and disturbing statement: some people should not be allowed to have children. So this narrative of undeserving motherhood has his foundation in our societal response to the crack baby hysteria. Crack babies, the worst threat is mom herself. And these attitudes, which we call stigma, which I'll unpack shortly, are common, and they're common amongst providers. These are data from nursing providers who take care of infants with neonatal abstinence syndrome, where, over 25% said that they frequently blame the mother of an infant with NAS for the infant's health problems. And these attitudes are common amongst medical students, interns, and residents, as illustrated in these data, where almost 50% of the people surveyed felt angry towards women who use drugs while pregnant. 38% thought that people who use drugs during pregnancy should not be allowed to retain custody. And the good news is that you can see something positive sort of happens with training. These rates are higher for medical students, and they decrease across the course of learning. And these articles use this word stigma to discuss this. And stigma is, from stigmata, the marks of the crucifixion of Christ. It's a mark on somebody else. It can be seen as a them problem. And I prefer the word discrimination or prejudice, because discrimination and prejudice are us problems. So we can do something about that. But one of the ways that we kind of express discrimination is through punishment. The first person who was punished for using drugs in pregnancy was in 1977. So this is a very recent phenomena, and it escalated greatly during the crack cocaine hysteria. And almost every state has prosecuted somebody for using drugs while pregnant. And the Guttmacher Institute sort of tracks state statute, and you can see the number of states here. I would say the first, 3 rows would be punitive, and the bottom 3 rows would be supportive policies. And the majority of states, have mandatory reporting. 3 states, it's grounds for civil commitment, and 23 states in DC consider using a substance while pregnant bound in state statute with child abuse. The thing to know is that these punitive policies actually worsen public health outcomes. Mandatory warning signs or collapsing substance use with child abuse or neglect on the population level increase the odds of low birth weight and preterm delivery and decrease the odds of prenatal care engagement. And CPS reporting requirements actually have no effect on those population health metrics. And when we look at states, we know actually the more punitive, or the states with punitive policies, have had a greater increase in neonatal abstinence syndrome compared to those that don't. And this is interesting to me. Generally speaking, drug policy is moving away from the punitive in the United States. We've had criminal justice reform. We have, there's a movement of decarceration. We have, legalization or decriminalization of certain substances, and particularly cannabis. But state policies related to drug use during pregnancy are actually becoming more punitive. The arc is moving in the other direction from general policy. And this is to a large extent driven by other state restrictive reproductive health policies. So, how do we counter stigma and how do we resist discrimination? Language is important. We can counter that dehumanizing discourse that was seen in the crack cocaine, headline and in Lindsay Jarrett's story. We can counter that by humanizing our language. We want to use language that's both evidence-based and person-centered. And there's been a really nice series of articles in the addiction literature focused on language. And here's a table sort of summarizing this. And you can see that the terminologies we should use are people-centered. Somebody, with, substance use disorder, somebody in recovery. We want to avoid, we talk about opioid use disorder. Abuse is DSM-4 and is, a charged term. And the one thing I want to call out relates to urine drug testing. We should not use words like clean and dirty to refer to biological sampling or any kind of test. We should talk about positive or negative, and just think as a thought experiment. If we talked about HIV tests in the same language that some people talk about drug tests, your HIV test came back and it was dirty. That feels horrible to say, and it is. Yet we are comfortable using those terms when we talk about substances. So really, the way we counter stigma and discrimination is by practicing empathy. And that means when we sit with patients, but also when we sit with colleagues, that we use people's names, that we smile, that we listen, that we don't interrupt, that we tune into nonverbal communication, the 93% rule, that 93% of communication is nonverbal. to be fully present when you're sitting with people. People pick up on attention and attitude very quickly and usually incredibly accurately. And really to take a personal interest. And this is not just to provide better care, but this is to be better healers and to protect ourselves, from burnout, from losing empathy is like the absolute worst place you can be as a provider and as a system. So these are my conclusions. Assessment for substance use should be universal in prenatal care. Treatment works. In fact, people who have treated addiction have birth outcomes that are very similar to the general population. But there's a marked attrition postpartum. So we really need to continue care through that 4th trimester. And we need to resist discrimination, and people who use drugs are a marked category subject to prejudice and bias and mistreatment. And if you say pregnant plus substance use, that is an even more, a population that experiences an even more profound discrimination. And really what resisting discrimination means at its core is treating all people with dignity and with respect. And with that, I'm going to stop. I hope you can see this whole, yes, you can, this whole slide here, because this is a resource that's underutilized. Full disclosure, I cover this line 1 day a week, but this is a free resource for providers. Provider meant, broadly, can be anyone who's not a patient. You can call and you will, get an immediate call back with any questions regarding substance use, with or without pregnancy, opioid prescribing, and etc. So with this, I'm going to stop. I think I stopped sharing the screen, and I'm looking forward to some questions.
Thank you so much, Dr. Terplan. That was wonderful. We do have several questions, so I'll dive right into those. So the first question is, the idea of ongoing care during the 4th trimester makes a lot of sense. What is our current state and capacity for this in the district?
So that's a great question. But I would say, we have the capacity. So there's 2 things. One is capacity, one is quality. So we have the capacity to provide prenatal care. It doesn't have to be the same set of providers, but probably, should be, or at least in part. I would say we definitely have the capacity to provide continuing care. Now, do we have the quality? Do we have the reimbursement? Do we have the motivation? Do providers feel like it's their responsibility? Those I'm less sure about. But I would say, I really feel like we need to redefine pregnancy. And we need to redefine it. It's not just, conception or wherever you want to put the beginning to delivery. It's wherever you put the beginning to 1 year after delivery. And that would be not just for live births, that would be for all pregnancies. And that would be helpful because one, that would, pregnancy definition would then map onto our, public health metrics, which include like maternal mortality and infant mortality, both of which are measured at 1 year of age. We should pay for services that way, right? So payers, should pay for that unit of time. And then providers should provide the care in there. It's not like I delivered the baby, I'll see you maybe once, and then, that's it until you get pregnant again. Like this, so, one of the things about addiction is like it's a chronic condition, right? And everyone says it's a chronic recurring condition, which it probably is, but historically, we've only ever provided episodic care. So the same thing for reproductive health. We provide episodic pregnancy-specific care, not life course reproductive health care. And that's really, what I think we should. So yes, I think there's no question we have the capacity. Whether we have the awareness, will, reimbursement, and et cetera, is a different question.
Great, thank you. Okay, so another question here says, is there a role for peers in this? Are there any existing programs you know of with peers who are moms with substance abuse histories?
Yeah, so great question. Short answer is yes. I think there's it's peers, people with lived experience, people in recovery. Peers can be defined in different kinds of ways, have, an essential role to play in society, and in communities as well as within the healthcare system. The evidence on peers is, actually it's decent, but it's not quite as robust as I think most of us feel like peers, are. And I think there are examples of programming around pregnancy and postpartum where people have used peers, but not a great evidence base for it. That's not at all a reason not to include them. I think there's some questions in that, like who is an appropriate peer? Does it have to be somebody who previously was pregnant and, let's say, delivered an infant that developed NAS? Or can it be, anybody in recovery? Or, and I think so there's a lot we don't know, and some of those questions might not really matter. But one thing I didn't say, but one of the reasons why the postpartum period is increased vulnerability, it's a gap, it's a shift it's a transition, it's a life transition, and it's a system transition of care that happens. And we know gaps are periods of vulnerabilities. When we think about like the classic example being like, criminal justice reentry. And I think there's actually a lot of parallels between delivering a baby and criminal justice reentry. And like the old term for delivery was, your date of confinement. So there's like a linguistic, resonance between that. And peers and having navigators or, have been helpful in, maintaining, some continuity of behavioral health care post-release. And I think there's a huge role for them in the postpartum period. And I'd be delighted to talk about details and look for funding with whomever is interested in doing this, because I think I think that's like that to me that's the best glue for that postpartum period that I know of as peers.
Thank you. We have another question here that says, what kind of training or capacity building is needed to support prenatal and postpartum providers to effectively integrate SUD care and/or collaborate with specialty providers?
Yeah, so both are important, clearly, right? So one, I would say behavioral health is an essential domain of wellness, and therefore should be, the province of all healthcare providers. And and addiction treatment is it's not, what do they say, like rocket surgery. It's not complicated, right? And almost anybody can do it. So I think basic competence in addiction treatment is completely within the realm of prenatal care providers. There's ACOG and ASAM have, there's a series of trainings that are free to get people waivered. We just completed a SAMHSA pregnant and parenting OUD course in the district, I think last week or the week before. There's lots and lots of resources. But that connection is also key. I think about what an average obstetrician gynecologist does. They know, this is what I do. I know a little bit about antihypertensive management. I know a little bit more about antidepressants. I know a lot more about addiction, but we all have our limits, right? So I'm okay with prescribing one medicine for hypertension. When it gets to 2, I start to ask for some help. That person's not stable on 2, I am no longer in good service of their health care. And the same is true of any chronic condition, including addiction. So there certainly are patients who need to see a specialist. But many, just like many non-specialists treat chronic conditions, addiction should not just be the province of specialty care. I'm happy to share those resources too, to help send out and et cetera. Just remind me.
Great, thank you. Another question here is, in the absence of a universal screening requirement from an organization, what are the most effective ways to reduce stigma on a provider-patient level?
That's a really good question too. So, I actually think that we need I mean, I think universal assessment during prenatal care is key, and I would say also on labor and delivery, I think we need to really think critically about the utilization of urine drug testing, in particular on labor and delivery, and we need to use it within like evidence-based guidelines, which we don't. I'm not speaking of any place in particular. I'm unaware of any delivery hospital that does. So I think that's actually all really important. Whether or not it changes stigma is a slightly different question. So the literature on stigma and providers is not super reassuring. There are examples of interventions and then the same, and with an evaluation with very little change. So I'm all in favor of trainings and awareness and reflection and et cetera. But I think that there are certain principles when we talk about this that are super helpful. One is to call out discrimination when we see it and when we hear it. Two is to model, anti-discriminatory practices in our language and how we sit and work with people. Three is to emphasize treatment. So that's, for that distinction I was making between treated and untreated disease, like when we focus on treatment, it actually has been shown in evidence to reduce like stigma and discrimination. And finally, I think we need to, act as professionals, act in a citizenship and public policy capacity, to advocate for, changing of regulations and legislation that adversely, affect people.
Makes sense. Thank you. Another question here says, are there any models of helpful, positive implementation of maternal health care for women who are in the criminal justice system?
Wow, you guys are great questions. So I'm not an expert in prison health, and it's a heterogeneous like system, right? Most people are in jails, and there's state prisons, and there's federal. And actually, federal with the least amount of people has the most organized health response, or most evidence-based health. I think you're also all aware that, prisoners are, the only population in the United States with a constitutional right to health care. That, again, not necessarily quality, but a right to health care. Nobody else has that right, just prisoners. All sorts of weird things happen in jails and prisons around, let's just say, opioid use disorder and pregnancy. It's hard to get national data because actually the numbers are probably not as low as we think they are, but they, let's say 5% or less. So that's not a very, that's kind of lost in the sea of mass incarceration. But weird things happen. So the benefit of medication during pregnancy is well enough established or well enough recognized by some jails that the only population of people who actually get access to medication are people who are pregnant. So I had a jail and a clinic in Richmond where we provided medication, for the people who are pregnant with opioid use disorder. Nobody else in the jail got access to medication. And they're weird. So one, as soon as, the person delivered and went back to jail, she underwent an involuntary, tape or detox. The other weird thing that happened was in the jail diversion space. So naltrexone is a medication that's used more often than the methadone or buprenorphine in, jail diversion programs. Naltrexone is not recommended for use in pregnancy. Therefore, when people, entered into that diversion program, if somebody was pregnant, they went to jail where they could get buprenorphine. But if they weren't pregnant, they were diverted. So inequities emerge, all around this topical area in ways that are really, complex. Am I aware of good programs? I think the program I worked in Richmond was okay. The pregnancy box was okay. It was like the two things I just mentioned, what happened after delivery and other stuff. But I really think it's the better way to look at it is providing access to all three medications for opioid use disorder for everyone, who's involved in the criminal justice system. And that's the model, certainly out of Rhode Island. And that would benefit people who are pregnant also. But my sort of policy suggestion would be to make it, that's a place where universal would make sense.
That makes sense. So there's another question here that says, can you speak to, or do you have any data that follows children after the fact of mothers who were on opioids during or before pregnancy?
Yeah, great question. I'm so glad somebody asked that, because this talk wasn't focused on that, and it's clearly a super important question. So yes, we actually know a lot about this topical area. There's the mother study, which was a randomized controlled trial of methadone versus buprenorphine. The primary outcome was neonatal abstinence syndrome. Those kids have been followed. They're about 8 years of age now on average. And there are no differences between those that had withdrawal and those that didn't, much less compared to sort of population health averages on all of the developmental scales that you can possibly think of. Generally speaking, so leaving aside alcohol is a teratogen. It causes birth defects. It's the leading cause of preventable intellectual disability in the United States. Sort of leaving aside nicotine, which might be like a neuroteratogen and is certainly strongly associated with adverse birth outcomes. Developmental ones probably, the evidence isn't quite as strong as for alcohol. Looking at all the illicit ones, which we spend a lot more time thinking about, the effects tend to be sort of similar across substances and tend to be overwhelmingly subtle when present, and they tend to, where things sort of like all come together is around executive functioning, measured by cognitive tasks in an fMRI around school age and stuff like that. The big take home for me, is that I think we overstate what the risks of in utero exposures to substances are, and we grossly minimize the importance of the caregiving environment on development. And I think societally we need to shift away from thinking about like in utero chemical exposure and more how do we enhance parenting and stability and safety in the caregiving environment, not just in the first year of life, which is critical, but across like early child rearing and et cetera.
Perfect. And then I think we have time for just one more. It's kind of a follow-up to the last question. Is there a role for the partner in all this?
Oh, that's another really great question. So the short answer is yes, but I'm with a couple of caveats. So one caveat is, not to make assumptions about who's people, like what a family is and who are the people in somebody's family. And this is a really good place to involve like the patient in the planning and the decision making. To ask them, who is your support? Who would you like to be involved, in your care and et cetera. The second caveat relates to, interpersonal violence and past or ongoing trauma. So we know that people who are pregnant with substance use disorder, are more likely to have histories of childhood abuse and neglect, and also more likely to be in current violent and abusive situations. Estimates range greatly because it depends how you ask. They range from towards 50% to 70, 80%. So I think you want to make sure that the person you're involving in the patient's care, their identified significant other people, is not somebody who is abusing them. But with those caveats, yes. And I think it's actually when we, there's a lot of, addiction and it's more than an individual. It is an individual condition, but it's also more than that. And really, you know, and same with, you know, parenting and child raising is more than just like, you know, a maternal behavior. It is like, it takes, and so involving other people in that, it can be done. There's some programs that do a very, very, very good job of that.
Thank you so much. We are just about out of time here, but I do want to say thank you so much, Dr. Terplan, for your time this afternoon. Bringing this perspective to our symposium has just added so much value, and it's certainly an area that we don't want to overlook when talking about the opioid crisis. So thank you so very much. We really appreciate your time.
Thank you.